Hello, I'm Professor Jeffrey Cummings. I'm the Joy Chambers-Grundy Professor of Brain Sciences and Director of the Chambers-Grundy Center for Transformative Neuroscience at the University of Nevada, Las Vegas. It's my pleasure to welcome you to this discussion on pharmacologic management of agitation in Alzheimer's disease. I'm here with Professor Krista Lanctôt from the University of Toronto in Ontario, Canada, and Professor James Galvin from the Miller School of Medicine at the University of Miami in Florida. We'll be talking about best practice in the management of agitation in Alzheimer's dementia. We'll start with the International Psychogeriatric Association, the IPA approach, which has been translated into Investigate, Plan, and Act, IPA. In terms of investigation, it's important to understand the behavior that the patient exhibits. Does the patient's behavior meet IPA criteria for agitation? What are the patient's characteristics? When do episodes occur? What precipitates them? What's the duration? What's the frequency of the episodes? Is there the potential for harm? If there's been an intervention, has the intervention worked? What was the response? Was it partial? Was it full? Were there any adverse events associated with previous pharmacotherapy? Then we need a plan. Let's construct an intervention that reflects the patient and their setting. Let's share the process of decision-making with the patient and the care partner. And then let's act. Implement the multidisciplinary team care plan with defined responsibilities for all team members. Implement all the appropriate psychosocial interventions, and then choose a pharmacologic strategy if that's appropriate. So here's an example of how this might happen. Of course, we always do psychosocial care. We do that before treatment with a pharmacologic agent. We do it during treatment with a pharmacologic agent. We do it after treatment with a pharmacologic agent. If the psychosocial intervention is not sufficient or there's immediate risk of harm, then we choose a pharmacologic intervention. That might be an intervention for a patient who has nocturnal or circadian agitation, or one with mild or moderate or mood features, or a patient with more severe agitation or antipsychotics, an antiepileptic, prazosin, nabilone, or a combination might be chosen. And if there's immediate danger of harm, then intramuscular antipsychotics or ECT would be considered. Psychosocial intervention continues throughout. So let's go to our panel now. We're considering questions that have come in from you, our audience. So Krista, I'm going to start with you. What role does good management of agitation play in optimizing patient outcomes? What are some of the important considerations for minimizing the occurrence and the severity of the episodes? Tell us what you think.
All right. Thank you, Dr. Cummings. First, it goes without saying, but it has to be agitation. Rule out other potential underlying causes like acute infection or delirium, but also look at recent medication changes and look for drug-drug interactions. For example, the drugs most commonly associated with aggressive adverse drug reactions might be antiepileptic drugs, sometimes antidepressants, sometimes benzos. And you always have to get this psychosocial intervention in place as a consideration for optimizing patient outcomes. In general, research has shown that some of the activity-based interventions, music therapy and massage, have shown benefits, particularly for agitation in nursing home residents, and also to look at having concomitant cholinesterase inhibitors in place.
Yeah, those are great ideas. Jim, anything to add to that?
Well, I just want to build upon what Krista said, is that I think the best defense is a good offense here. So in other words, thinking about what are some of is this patient a patient at risk for developing these behaviors, so that you can have a plan in place before the behaviors begin. So while you're looking for reasons that person might have behaviors, as you're evaluating your patient, is this a person who has otherwise predisposing traits that might lead to agitation and aggression behaviors? So I think, again, thinking about this ahead of time might be really important, so that when you develop your plan, you can take into account the things that you have to remove, the insults, but also what are some of those predisposing risk factors?
Yeah, great. Thanks, Jim. And what about monitoring protocols for patients who are on pharmacotherapy? Are there protocols that are helpful in terms of helping physicians decide when to escalate therapy or to de-escalate therapy?
Well, I think one way we can think about this is what kind of tools we're going to use. We can do interview strategies where we do semi-structured kind of interviews with the patient and the care partner. But we can use tools. So like, for example, the neuropsychiatric inventory. And if we collect that data before, then we have a better sense, one, if someone's at risk, how that behavior's changed and how much distress it's causing to people. And then if we're doing something, we can then monitor whether those things are changing. So we can do sort of more of a screening approach. And then, of course, there are tools specifically for agitation that we can use to monitor whether a person's responding to therapy.
And Krista, anything to add to that?
No, I agree with what Jim said, but just for monitoring in general, it's kind of a 1, 2, 3. Most randomized placebo-controlled trials would show efficacy for any interventions at least by 4 weeks. Switching treatments is recommended usually around 8 weeks after 2 months, and guidelines recommend that for monitoring, you would assess at least 3 months later and certainly every 6 months.
Yeah, one of the things I was thinking about is if I have a patient who goes, say, 3 months with very minimal agitation, that's when I would start backing off of the dosing of that patient to see whether they relapse. Of course, there's a high chance of relapse, but if they've been very stable with minimum symptoms for 3 months, I would say that's a time when we can start to experiment with removing the medications. So let's go on to when pharmacotherapy is indicated. What are some of the key considerations to guide treatment selection and patient management and monitoring? What are your thoughts there? Krista, let's start with you.
I guess, I think you already mentioned it, but it's the history of response and the history of side effects. So you look at the history. You're going to look at concomitant medications. Are they already on cholinesterase inhibitors? To guideline treatment selection, you'll want to look at the severity of agitation, and you already showed that in the IPA algorithm. If it's more mild, you might consider something like citalopram or escitalopram. More severe, you would want an atypical antipsychotic. You'll want to look at the severity of cognitive impairment. That's been one of the predictors of response. Citalopram worked better in people with more mild cognitive impairment. Other drugs like nabilone were tried in people with severe cognitive impairment. And importantly, you have to look at the concomitant neuropsychiatric symptoms. Do you want sedation? Do you want something? Do they have a mood neuropsychiatric symptom? So you want citalopram with mood. If they have psychotic features, you want an atypical antipsychotic. And concomitant underlying illnesses. Do they have QTC prolongation in the past? Are they on something that's already prolonging the QTC interval? So I think that those are some of the key considerations.
And Jim, what would you add to that?
Well, Krista took all the good answers. So what I would say next is one of the things that we've moved into with our clinical practice is to begin to use the concept of pharmacogenomics and see if we can get a better sense of what medicines might be the best selection for the patient based on their genotype and understanding, their folate metabolism, the cytochrome P450 system, and other types of things. Are they smokers or non-smokers? And all of these things do play a role into what's the likelihood of medicine will be well tolerated and avoiding adverse events.
Great, thanks. And the one thing I would add to this is you would choose your monitoring based on the type of intervention. So if you're working with an atypical antipsychotic, you're going to be particularly sensitive to extrapyramidal symptoms, tremor, Parkinsonism, bradykinesia, those sorts of things. So the nature of the intervention also guides the type of monitoring that would be done. So these are great answers. Thank you so much for this information. Really appreciate it. Thank you. In this section, we'll be talking about the pathophysiology of agitation in Alzheimer's dementia and new approaches to treatment. Agitation in Alzheimer's disease is associated with changes in a variety of neurotransmitter pathways. There's noradrenergic system hyperactivity with heightened emotional drive from the amygdala and the prefrontal cortex. There's decreased serotonin signaling, which leads to impaired cognitive and behavioral control, increased aggression and impulsivity, and dysregulation in the dopamine system. That dysregulation then is associated with increased risk of agitation and aggressive behavior as well as psychotic behaviors. Agitation in Alzheimer's disease is a frontal lobe syndrome with notably abnormal activity in the orbital frontal cortex and the anterior cingulate cortex. If we look at the new therapeutics approved and emerging, they reflect these transmitter abnormalities. For example, AXS-05, which is under development, targets the NMDA receptor system as an antagonist and the sigma-1 receptor system as an agonist. The impact is an influence on mood and behavior through modulation of NMDA receptors and stimulation of the dopaminergic system. Brexpiprazole is approved for the treatment of agitation in Alzheimer's dementia. The targets now are noradrenergic alpha-1b and alpha-2c, as well as serotonin 5-HT2A receptor antagonism. It is also a partial agonist for serotonin 5-HT1A and dopamine 2 receptors. The impact is suppression of multiple receptors related to agitation, aggression, impulsiveness, arousal, and psychosis. If we look at nabilone, the targets are the cannabinoid receptors, CB1 and CB2, where nabilone is a partial agonist. In terms of potential impact, there's increased serotonergic signaling, and interesting, there's evidence of neuroprotection through reduced oxidative stress, reduced TNF-alpha, and reduced glutamate release. There's also an impact on improved circadian rhythm disturbances. So let's go to our questions that have come in from our audience that address these questions related to the pathophysiology of agitation in Alzheimer's dementia. So Jim, I'll start with you. What are some of the limitations of our current pharmacologic options for AAD?
Well, Jeff, it's a great question. I think one of the great limitations with our current battery, not including the medications you just discussed, was that we really didn't have anything that was particularly targeted toward agitation. So we were borrowing medicines that were indicated for other conditions and trying to find the right combination, often as a hit and miss trial and error perspective. I think what's being developed is actually giving us a much more targeted approach at treating this problem, which is disturbing to patients and very disturbing to care partners.
Thank you. And Krista, what would you say? What are the major limitations that you can see for pharmacologic options for AAD?
I agree with what Jim said. And, for some of the medications that are currently used, there's really limited data supporting their efficacy and their safety. People use gabapentin, but there's no randomized placebo-controlled trials. Carbamazepine has one RCT, but it's small. For prazosin, the PSAD study was limited during COVID, so we ended up only having something like 35 people randomized. We know orexin is a key modulator of the sleep-wake cycle, and that's dysregulated in Alzheimer's disease, but for orexin, there's no big trials. And trazodone is based on the Terry trial in 2000, so we don't have strong evidence for trazodone, even though it's used. So drugs that were previously used don't have a lot of support, and they're not approved, so they're used off-label. And the second point would be it's very difficult to predict response from the biomarkers that we have now. So we don't know which patient will respond to which medication.
Thank you. Yeah, I think the weakness of the data and the emerging double-blind controlled information is so useful. So what implications might the different drug mechanisms that we've talked about have in clinical practice, both on the safety side and on the efficacy side? And do you think there's scope for combination approaches to managing agitation in Alzheimer's dementia? Let's start with you, Krista.
I think it's important to recognize that we think that agitation in Alzheimer's disease is associated with the noradrenergic, the serotonergic, and the dopaminergic system. Brexpiprazole works on multiple neurotransmitters, so it can also improve psychotic symptoms, and it's the non-sedating choice. AXO5, again, works on multiple neurotransmitters. It can also improve depressive symptoms, and it can sometimes be sedating. It works through the sigma-1 receptor, but that can also enhance glutamatergic and cholinergic synaptic neurotransmission. And the dextromethorphan part can inhibit serotonin and norepinephrine transporters. So they're all targeting multiple neurotransmitters. And CB1 and CB2 can be anxiolytic, increase appetite, decrease pain. So I think that when you look at the different, it's an exciting time because we now have some novel medications that work through different systems. And you can target some of the, not only the agitation, but the concomitant neuropsychiatric symptoms. And you asked about combination approaches. I know that for the citalopram AD trial and the nabilone trials, they were real-world trials. So they, nabilone, for example, we tried it with atypical antipsychotics. The patients were on that, and they were also on antidepressants. So there is some precedent for combining these medications and using them in a sequential way and having add-on therapies when the first one doesn't work. If you look at it on paper, we don't want to try more than one drug at one time for agitation, but sometimes with severe agitation, if you have a partial response, you may want to consider an add-on medication.
Yeah, good ideas. Jim, anything to add to this idea of the mechanisms as they apply to clinical practice or combination therapies?
Yeah, I mean, it's really tough to follow Krista. She's pretty comprehensive in her answers, but I think just to add to that, I think as we move into the world of precision medicine approaches, having options that allow us to specifically target, different neurotransmitter systems and the ones that we know are responsible for agitation. So having drugs available like brexpiprazole that target the 3 neurotransmitters most associated with agitation in Alzheimer's dementia is going to help us help our patients and their care partners. Alzheimer's is a complex disease. Complex disease often require considering multiple approaches. And so I think there's going to be a role for in the right patient using a combination approach.
Thank you. And I would just add from a kind of conservative point of view that not only can we get additional efficacy from combinations, but we can also get additional side effects from combinations. And it's very important that the doctor or clinician be very vigilant about emerging side effects when we're using 2 medications that may have different safety profiles. So how can clinicians choose between new and emerging pharmacologic therapy strategies when considering them for a given patient? And Krista, I'll start with you because of this second part of this question. Are there any biomarkers that would help us guide treatment decision-making?
Unfortunately for biomarkers in clinical practice, it's still trial and error, but it's an exciting time because we are moving towards precision psychiatry. There is not a lot of data yet, but it is emerging. We've done some work looking at biomarkers in the context of clinical trials. In our nabilone trial, we looked at potential biomarkers of interest related to either the mechanism of action of the drug or underlying agitation. So I think those are the 2 approaches that you have to take. For underlying agitation, we looked at, of course, neuroinflammation, so a peripheral marker of neuroinflammation, because that's one of the markers that's been consistently associated with agitation in Alzheimer's disease. And we found that low TNF-alpha predicted response to nabilone. The biomarkers or predictors that we have right now are mostly based on the clinical predictors. So for nabilone, we found that baseline pain, having depression, anxiety, and apathy were strong predictors of response as well. the same as in citalopram trial. The people who were least cognitively impaired and only moderately agitated and not in long-term care and not prescribed lorazepam responded. So I think the exciting thing is going to be taking these clinical predictors, but also using precision medicine with plasma-based biomarkers or imaging biomarkers in the future and putting those together. And I think that's how we can truly move forward in this area.
Thank you for that. And Jim, how would you advise clinicians about choosing among pharmacologic alternatives?
Well, I like to practice a concept of shared decision making. So while I have thoughts about what medicines might work and whether we're going to use these new and emerging medicines, I think having a discussion with the patient and probably more importantly, the care partner to understand, all the potential benefits, but also what are some of the potential adverse events and how prepared is that care partner to be observant and looking for these things. So for example, if there's, some subtle signs of some Parkinsonism, doing something that's a D2 partial agonist or antagonist might enhance that. So I think it's a combination of thinking about what's the best medication for the patient in front of you, taking into account all of the factors, including sort of the psychosocial and care partner factors. But also, what are the resources they have available to them? Because I think it's important to always consider, what are the options we can offer our patients that are also going to be affordable and make sense for that patient. So I think it's a bigger discussion sometimes to have.
Thank you. Very wise guidance. Thank you all. Now we'd like to consider advances in treatment of agitation in Alzheimer's dementia, a discussion of the first approved therapy and novel approaches that are on the horizon. So we're looking at 3 drugs here: brexpiprazole, which has completed a phase 3 and is approved for the treatment of agitation in Alzheimer's dementia; AXS-05, which is an experimental agent that has completed phase 3 studies; and nabilone, which has completed a phase 2 crossover study and is in phase 3. Let's start with the population of the brexpiprazole study. There were 345 patients included in the trial, 228 on brexpiprazole and 114 on placebo. The main outcome here was a drug placebo difference and change from baseline on the Cohen-Mansfield Agitation Inventory, which is a commonly used assessment of agitation. And you can see that there was a statistically significant difference in favor of brexpiprazole on the differences in change in the CAMI. From a safety point of view, brexpiprazole had treatment-emergent adverse events in 41% of patients, where there were 31% of placebo patients who had such events. Discontinuations were very similar for brexpiprazole, 5%, and placebo, 4%. The AXS-05 trial that we're showing you here was a randomized discontinuation trial. So patients, all of whom were included into the trial, were put on AXS-05 for the first portion of the study. If they responded to therapy, they were then randomized to placebo or to continue on treatment. And the outcome was time to recurrence of agitation. You can see that there was a high response rate in the open label portion of the trial with a highly significant drug placebo difference from baseline. After the randomized discontinuation, there was a substantial delay in the time to relapse on the treatment group compared to the placebo group, and this was statistically significant. In terms of treatment-emergent adverse effects during the double-blind period, there were 28% of AXS-05 patients with such symptoms, and 22% of patients on placebo with such symptoms. Discontinuations were lower in AX-05, where none occurred, and 2% of placebo patients had discontinuations. If we look at the nabilone columns here, There was a small phase 2 double-blind crossover study, and there was a Cohen's d effect size of 0.5, which is medium and quite good for psychotropic agents in favor of treatment with nabilone. In terms of treatment emergent adverse effects, there were significantly more in the nabilone phase compared to the placebo phase of the crossover design. In the phase 3 study, it is currently ongoing, and we'll see the difference in the CAMI if it occurs, with a readout expected in October of 2025. Let's turn to our panel for questions now. Krista, I'll start with you. Based on available efficacy data, how will the new and emerging agents contribute to improving outcome for patients with AAD?
Thanks, Jeff. Well, there's no question that agitation is associated with negative impacts on both persons with dementia and their care partners. So it's important to treat. We know that agitation is associated with, for example, an increased rate of cognitive decline, increased mortality, and visibly decreases in quality of life. It also has an impact on the care partners. It's associated with their quality of life, and it's a major cause of caregiver distress. So new and emerging treatments, we have hope for them that they will work on all of these outcomes. All of the new treatments have different mechanisms of action, so it adds more to our armamentarium that we can treat patients with. As we saw from the data that you just presented, they have a small to medium effect size, but we will be able to choose from different medications. I know that Brex has a black box warning associated with its mortality as well. So we'll see how that balances out over the long term.
Jim, what would you like to add to that?
Well, I think just to add to what was already another great answer from Krista is that one of the things I think that's going to really make a difference is if we can reduce some of the symptoms pharmacologically, that might make our non-pharmacological approaches more efficacious. And ultimately, we may not have to keep people on medications for a long period of time. So I think one of the things that I would really be interested in as we start to use these medicines more and more is, how can we get people eventually off medicine but maintain them without this agitation that can occur and is so disturbing to the patients and to the family.
Yes, thank you. And one of the things I think about is we're moving towards personalized medicine. And so maybe as these other drugs, if they're approved, if they're successful in their clinical trials, we'll know more about, well, what were the response profiles and how did that map onto the symptoms at baseline? And are there risk factors associated with the different drugs that we can understand and apply in personalized care? So I'm looking forward to having that information. So what are the new and emerging agents for treatment of agitation likely to fit into the paradigm of treatment for agitation in Alzheimer's disease? Jim, how do you think we're going to integrate these new drugs into approaching our patients?
Well, I think that the first choice is always going to be try to do a non-pharmacological approach, right? So look for inciting activities, and then also look at some of the non-pharmacological therapies. And if they work, that's great. If they don't work and medication is being considered now, in most cases, I think we haven't been really happy with the results that we've gotten from the available medications. And so I think these new and emerging agents are really going to move to the top line for the management of these symptoms if they require medication. So I see a shift to being more commonly used earlier in the course of managing agitation in Alzheimer's dementia, following the non-pharmacological approaches.
Yeah, good point. Krista, do you have something to add to that?
Great answer, Jim. I think that they will still fit into the IPA treatment algorithm, but hopefully they will move up. And I think that in the future, you mentioned biomarkers, but we'll also have some biomarkers that are associated with, for example, glial activation and oxidative stress that will give us some idea of whether some of the medications that are being used are more neuroprotective and what's going on in the brain, and perhaps in that way address some of the problems with increased rate of cognitive decline and increased rates of mortality that we see as outcomes. Right now, that's pie in the sky, but hopefully we can use monitoring biomarkers as well to have some idea of what's going on neurologically.
Thank you. And Krista, you know that these questions actually came in from our audience, so we're trying to be very specific in our answers. One of the things they wanted to know were, what are some of the key concerns for the short and long-term use of new and emerging therapeutic agents, and how can clinicians manage them in their care approaches? You want to start with that?
Thanks, Jeff. So short term, you're going to want to, depending on the medication, you're going to look for key side effects, QTc interval. We see cognitive impairment sometimes as a side effect that we detect typically in those with milder Alzheimer's disease dementia. There's always the possibility of sedation and falls, depending on whether you're using a sedating medication or not. And as we mentioned already, as a long-term effect, the possibility of increased mortality, either with the medication itself or over longer term, possibly associated with the agitation. So you're going to look at lack of efficacy in the short term and reassess, and any safety problems. And then there is the lack of long-term data for a lot of these medications. So we still don't know what happens over the long term, and that's an area of need for research in the future.
Very good. Jim, what would you like to add to that?
Well, again, to build upon what Krista said, I think that, looking for efficacy signal, is the agitation reduced? Tolerability, so is the person tolerating a medicine and adhering to the medication? And 3, what are some of the treatment emergent side effects that are going to be a little different from each of the new and emerging therapeutic agents? And then I think one of the things we're going to have to learn is how to manage this, right? So in the short term, are simple dose adjustments able to manage the symptoms? That would be my first choice before adding another medication. But if we need to add another medication, then thinking about the right combination for our individual patient, thinking about them as an individual rather than sort of a one-size-fits-all approach. And I think the last thing will be, as Krista mentioned, that long-term management is with the black box warning. Is this going to be something that I'm going to have to acknowledge and follow, or is this something that I'm going to see and I don't know what's going to happen, as these new medicines are available? In my career, I haven't seen a lot of the long-term consequences associated with the black box warning, but I have to talk to all my patients about the fact that it does have a black box warning.
Yes, thank you. And I would just emphasize one thing that Krista said, which is that the trials are relatively short. And so our information about the long-term consequences of these drugs is not as robust as we would like. So we are all learning with the long-term use of these drugs. Thank you. Thank you to the panel.